Okay, so we move on within the radiotherapy session. I would like to introduce Henry Weatherburn from the UK. And he will present a comparative longitudinal observational cohort study. So, Henry, please.
Yes, thank you. Good morning, everyone. And it's my pleasure to be here to discuss our comparative longitudinal observational cohort study of fractionated superficial radiotherapy for the treatment of Dupuytren's disease. John Glaze, my fellow author, has had to return to London today to chair the RAD Society, so I'm giving the presentation. Neither John nor I has any conflict of interest to report. I shall start by reporting on our audit of early progressive Dupuytren's disease treated with superficial radiotherapy between January 2007 and June 2021 at Cancer Centre London. Our audit aimed to compare outcome with previously reported audits from other centres of untreated patients, patients treated with surgery, or patients treated by radiotherapy. Over 400 patients, 620 hands in the audit, 31 were treated by LINAC electrons and 589 by superficial X-rays. Some patients required more than one field, for example, for knuckle pads, and the DEGRO 15 gray and 5 fraction with a 2-month gap, then a further 15 gray treatment schedule was used. A pilot study of thermal imaging was undertaken from 2011 to 2015, in which the consultant used a calibrated thermal image camera to inform treatment field markup using temperature perturbations. The results were reported at an RSM conference in 2016, namely that thermal imaging was a useful adjunct to improve radiotherapy planning of Dupuytren's treatment. An example is shown here. On the left is the thermal image, and on the right is the treatment field. And the treatment field is larger than it would have been just doing the markup which was described by the previous speaker. Returning to the audit more generally, this covered January 2007 to January 2025. So that was 18 years with a minimum follow-up period of 3.5 years when the last treatment in this group was finished, and a mean of 8 years. Recurrences requiring retreatment were identified and compared with untreated Dupuytren's disease progression, Dupuytren's disease progression post-surgery, observation of treated and untreated progression at 8.5 years, and a 13-year audit of radiotherapy treatment outcomes. Turning to our results, 95% of the patients were treated by superficial X-rays, mostly at 100 kV, and only 5% by electrons. Initially, a superficial X-ray unit wasn't available, but transition to this was undertaken when it was available, as it became clear that there were lesser resource requirements than the LINAC, and there was greater ease of positioning for patient treatment. Our next result was that increased field sizes, as I mentioned, generally resulted from the use of thermal imaging. Excuse me, sorry. Yeah, regarding the Dupuytren's recurrence, our key result was that our result of Dupuytren's recurrence was low, and only 4.3% for patients and 3.1% for hands requiring retreatment. The period for recurrence was 2 to 7 years. Skin dryness and erythema were not major issues, and no cancers were induced. In a previous CCL audit, which was reported in 2016 at Estroll, a 4% recurrence rate was also found, but this was only after a period of 2 years. But one must note that smaller field sizes were generally in use then, while the audit was ongoing. Reported audits from other centres also identified recurrence rates outside of treatment fields as 19%, and this was from Ziegenschmidt, and 5 to 9%, 5 or 6% from Betts. Together, these results point in the direction that larger fields reduce recurrence. Our 4% recurrence rate, a mean period of 8 years, compares favourably with untreated progression rates of 37% at 3+ years and 47% at 6+ years, and similar recurrence rates after surgery, fasciectomy, as reported by Malaysia. Also, untreated progression of 62% or 52% stage progression after a mean follow-up of 8.5 years, as reported by Ziegenschmidt. And finally, 13% stage N and 30% stage N1 recurrence rate was reported by Betts following radiotherapy in a 13-year audit period. In summary, our findings were use of superficial radiotherapy was found to be very effective and uses fewer resources than a LINAC. Secondly, for a mean follow-up of 8 years, recurrence of Dupuytren's requiring further treatment was 4%. While randomized controlled trials are ongoing, our results show improvement over no treatment, surgery, or previous longer-term radiotherapy audits. Improved target identification using thermal imaging and resultant larger treatment fields offer an explanation for these improved radiotherapy results. In conclusion, application of this approach as described should generally improve Dupuytren's disease treatment outcomes. And these are the references, and I'd like to thank you for your attention, and I'd be happy to endeavour to answer any questions you may have. Thanks.
Thank you. Other questions?
No.
I might just ask a quick question about where are these patients coming from? Are they sort of being referred from general practitioners or hand surgeons to your practice?
A variety. Basically, some of them come from the hand surgeon who you had in a previous reference, Andrew Fleming, who was saying that radiotherapy needs an RCT, yet he actually refers patients to us.
Thank you very much for this talk. You compare your results with the results that were published by Milesi in 1974. Do you think that the patient characteristics of your patients were comparable to those of Milesi?
Well, it's a good point. I think it's such a lot. They're early stage patients. But they are quite a large sample. So, I mean, we've treated over 600 hands, and I think it would be highly probable that the 100 or 50 or so in the other sets of patients would form a good subset. So I think that we should be covering those characteristics too.
Okay, thanks, Henry. We're going to have to keep things moving along, so great presentation.